30 seconds. I mean, think about how fast that actually goes by. It's half a minute. It's the time it takes to tie your shoes or maybe pour a quick cup of coffee. But in the neonatal intensive care unit, 30 seconds is the absolute, non-negotiable maximum window of time a medical professional has to safely place a breathing tube into the airway of a critically ill premature infant. Just let that sink in for a second. The clock is literally ticking, the stakes are life and death, and there's absolutely zero margin for error.
Welcome to The Explainer. I am so incredibly excited to guide you through today's topic, because we are looking at what is arguably one of the most high-stakes, adrenaline-pumping procedures in modern medicine. Today, we're unpacking exactly how doctors beat this clock, how they protect their tiny patients, and how they manage to train the next generation to perform under such unimaginable pressure.
So, let's get right into it, because the fundamental challenge here is honestly a little hard to wrap your head around. How do you safely place a breathing tube in a patient who might weigh less than a single pound? We are talking about extremely low birth weight infants. These are micropreemies, whose airways are incredibly fragile and quite literally microscopic in scale. Every single movement must be perfectly calculated, simply because the physical anatomy we are dealing with is breathtakingly small.
Now, what's really interesting here is the sheer scale of the equipment required. For babies weighing less than 1,000 grams, so again, we're talking under 2.2 pounds, doctors have to use an endotracheal tube, or ETT, that is only 2.5 millimeters in diameter. To put that into perspective, that is roughly the width of a single piece of dry spaghetti. Trying to expertly guide a tube that tiny into an airway that is even smaller, all while a stopwatch counts down, it's a monumental medical challenge. And the reason they're racing that clock so hard is because the alternative is just devastating. If intubation requires multiple failed attempts, the infant is at risk for severe tracheal intubation-associated adverse events, or TIAEs. And we're not talking about minor hiccups here. We are talking about cardiac arrest, pneumothorax, which is a collapsed lung, direct physical trauma to the airway, and severe interventricular hemorrhage, which are extremely dangerous brain bleeds. The stakes couldn't possibly be higher, which is exactly why preparation is absolutely everything.
Section 1. Preparing the tiny patient, a calculated chemistry.
Right, so you obviously don't just jump into this 30-second window totally blind. The clinical pathways dictate pre-medicating the infant first. And this isn't just about making them comfortable, though of course that is important. The ideal strategy here eliminates the pain, the discomfort, and the physiologic abnormalities of the procedure itself. Essentially, the whole goal of these drugs is to temporarily freeze the baby's biological responses. You're trying to prevent their tiny bodies from going into a state of shock or trauma while the tube is being placed.
So what's actually in this chemical safety net? Well, it usually kicks off with atropine. This is what's known as a vagolytic agent. You see, when a tube goes near a baby's airway, their vagus nerve can get stimulated, causing their heart rate to just plummet, a condition called bradycardia. Atropine specifically blocks that response, keeping the heart rate nice and stable, while also drying up salivary secretion so the doctor can, actually see what they are doing.
Next up, we have pain control, and this brilliantly illustrates just how specialized neonatal care really is. The preferred drug here is fentanyl. Now, while you might know it from the news in totally different contexts, in the NICU, it's chosen for a very specific medical reason. It acts rapidly, sure, but more importantly, studies show it has a remarkably stable impact on the infant's systemic and cerebral blood pressure. It effectively manages the pain without crashing the baby's incredibly delicate circulatory system.
Finally, to stop the baby from fighting the ventilator and to prevent chest wall rigidity, muscle relaxants like rocuronium or succinylcholine are used. But, and this is a massive caveat highlighted right in the clinical pathways, you only administer these paralyzing agents if the team is completely 100% confident they can intubate quickly. Because think about it, you are taking away the baby's ability to breathe on their own, which means the medical team has to step in flawlessly.
Section 2. The 30-second window. Beating the clock. Okay, the drugs are in. The heart rate is stabilized. The baby is relaxed. Boom! The clock starts right now. The physician takes the laryngoscope, which is the instrument used to view the vocal cords. Step 1, lift. Do not tilt. Tilting can act like a lever and cause severe damage. Step 2, they must carefully avoid any trauma to the baby's fragile gums and lips. Step 3, visualize the microscopic vocal cords and smoothly insert the endotracheal tube. Every single physical movement has to be completely devoid of hesitation.
But here's the thing. It isn't just about getting the tube in. It's about extreme depth precision.
For a 23 to 24 week gestation micropreemie, the tube should only go in about 5.5 centimeters at the lips. Pushing it even 1 centimeter too far, that means you could enter just one of the main bronchial branches, or worse, perforate the airway entirely. The margin of success here is quite literally measured in millimeters.
So the absolutely crucial point here is knowing exactly when to stop. The protocol is merciless. You must abort the procedure if 30 seconds pass, if the baby's heart rate drops despite the atropine, or if any bleeding occurs. If you fail, you pull out, you go back to providing oxygen with a bag and mask, and you stabilize. Because patient safety always trumps getting the tube in on the very first try.
Section 3. Improving the odds. Technology intervenes.
Now, I know all of this sounds incredibly high risk, but thankfully, doctors aren't just relying on the naked eye anymore. For decades, the standard was direct laryngoscopy. That's where the doctor physically leans over, looks down the blade into the baby's throat, and tries to spot the tiny vocal cords. But today, the clinical pathways strongly prefer video laryngoscopy. This involves placing a tiny, high-definition camera right at the tip of the blade, projecting a crisp, magnified view of the airway onto a screen for the entire medical team to see.
And the data backing this up is pretty striking. We're talking about a recent randomized controlled trial that showed utilizing video laryngoscopy resulted in an 89.3% first-pass success rate compared to just 78.9% for the traditional direct method. When you only have 30 seconds to spare, a 10% bump in getting it right on the very first try is absolutely massive for patient outcomes.
Because remember those severe adverse events we talked about earlier? Well, video laryngoscopy actively combats them. It leads to fewer overall intubation attempts and a mathematically proven reduction in airway trauma. But there's also a hidden third benefit here. Because the airway is projected on a screen, senior doctors can actually watch what junior doctors are doing in real time. They can give immediate feedback without having to push them out of the way to look down the baby's throat themselves.
Section 4. Training the next generation of experts.
Let's move to and see how this builds, because how on earth do you actually teach a young doctor to perform this terrifyingly delicate procedure? Well, the learning curve is steeper than you might think. Data from the National Emergency Airway Registry shows first-attempt success rates heavily rely on experience. Fully trained neonatologists sit at about 60%, fellows at 53%, but pediatric residents, the doctors still early in their training, only succeed on their first try about 23% of the time.
And this brings us to a fascinating, kind of ironic modern dilemma detailed in the literature. Because neonatal medicine has advanced so much, we are actually much better at supporting premature babies using non-invasive ventilation. That means we don't have to intubate them as often. Now that is wonderful for the babies, but it means today's pediatric trainees actually have significantly fewer real-world opportunities to practice this life-saving skill compared to doctors practicing 20 years ago. So, to bridge this gap, hospitals have set up a pretty relentless simulation gauntlet. Before a trainee ever even touches a live infant, they must undergo extensive review, observe video techniques, complete intensive simulation training on high-tech mannequins, utilizing both direct and video scopes, and then pass a strict proficiency exam scoring at least 90%. Plus, the whole medical field has actually shifted how it grades these doctors. It's no longer the old see one, do one, teach one mentality. Competence is now measured by entrustable professional activity levels, or EPAs. You move from novice to expert not just by logging a certain number of procedures, but by demonstrating strict, observable skill milestones. You have to prove you can do it consistently before you earn the right to do it without direct, over-the-shoulder supervision.
But listen, even with all that intense training, the clinical pathway mandates an ultimate safety net. A trainee is allowed a maximum of 2 attempts. That is it. If they are unsuccessful, a highly skilled provider, like an attending neonatologist or specialized respiratory therapist, is legally and procedurally required to step in and take over the airway. The tiny patient's safety is never, ever sacrificed for the sake of education.
So, we've covered the microscopic anatomy, that intense 30-second window, the incredible chemistry, and the high-tech training. But I want to leave you with a thought to ponder as we wrap up this explainer. As our medical technology continues to advance, constantly reducing the need for invasive procedures, how will the next generation of frontline doctors master these vital manual skills for those moments when every single second counts? It really is the great balancing act of modern medicine. Thanks so much for joining me on this deep dive. Stay